His research interests include novel therapies for thyroid carcinoma and recombinant human TSH. He is co-author also of the American Thyroid Association guidelines. Dr. Tuttle has probably devoted practically his whole career to thyroid cancer. He is an endocrinologist at Memorial Sloan Kettering. He's also professor of medicine at Joan and Sanford I. Weill Medical College of Cornell University in New York. He's an active clinician and researcher specializing in the management of advanced thyroid cancer. He travels extensively, both within the U.S. and abroad, lecturing on the difficult management issues in thyroid cancer. His research projects in radiation-induced thyroid cancer have taken him from the Marshall Islands to Washington State to regions in Russia that were exposed to fallout from Chernobyl accident. He serves on the American Thyroid Association Committee, also chaired the National Comprehensive Cancer Network Thyroid Cancer Panel, and served on the Endocrinologic and Metabolic Drugs Advisory Committee of the U.S. Food and Drug Administration. Holy cow. So, I mean, we've got two powerful people here, so we can hardly wait.
So this session, I think, it's a little after 4. So this must be the one on treating complications of targeted therapy, right?
Right.
We're in the right place? Okay. So Mike and I are sort of the Abbott and Costello here, the Sam and Dave routine going on. We won't have you figure out who's the straight man and who's the funny man. But for this session, we would like to take a broader view of what represents targeted therapy. Because in fact, in papillary and follicular cancer, radioactive iodine is a targeted therapy. And TSH suppressive thyroid hormone is a targeted therapy. And so for our perspective, we would like to consider your questions in the realm of treating the complications of targeted therapy to include radioactive iodine, TSH suppressive thyroid hormone therapy, as well as the new systemic chemotherapies. And we'll do a coin flip as the questions come in, and if it seems like something he knows, then I'll answer it. And if it's anyway.
I try to help him out a lot. So
we're
doing our best here to see where we go.
Now you know who the straight man is, right? I set him up every time.
The two of us travel just a little bit too much together. Although seldom do we get to do this together. It's always one after the other. So when we found out, we're like, oh, this will be fun. Let's do this. Let's bring 0 slides and see what you guys can stump us with. So we'll open it up from there. So what specific questions or topics do you have or you want us to talk about? We're open. Yes?
Come use the microphone.
Yeah, I should tell you, they are going to videotape this, and I have no idea why. Yeah, I told them yes.
We're recording this?
We are recording this, so... But
me. Okay.
I'll dub it and all that sort of... The singing comes later.
So disclaimer, I'm a patient at one of your institutions.
Uh-oh.
The good one?
Go Longhorns. So I've been there 5 years now. I have some progressive disease. I've been in watchful waiting, and I'm wondering, when does it go from watchful waiting to something a little bit more assertive? At what point?
Yeah, I wish I knew the answer to that. I will tell you, I struggle with that every day. It's easy for us to give lectures and say, theoretically we watch, and then at some point we do something. It's easy when you're on the stage. When you're in the room with one person, trying to decide with you, where do we draw the line? So in our perspective, if things are really small, less than a centimeter, and growing really slowly, we wouldn't even think about it. We generally watch. It's when they get bigger than a centimeter that we technically begin to think about it. But Steve, where do you draw the line? I mean, we got lots of these folks that got 1.5 centimeter. They come see you, maybe they've been stable for 2 to 3 years. Where do you say it's time to stop watching and we need to intervene and do something?
So there is no line, okay? It's a gray zone. And for different patients, there's going to be a different appropriate starting point. Part of that is because the rate of growth can be quite different from patient to patient. But quite frankly, I can have two patients with the exact same cancer, the exact same amount of cancer, the exact same rate of growth of the cancer. But they may start therapy at different times because there are aspects about the balance, the trade-off in risk and benefit that will vary from person to person. Meaning there has to be a dialogue between me as the physician and the patient about what's going to be right for them. And why is that? Why isn't there a simple answer? It's just, you cross that threshold, now you need to start therapy? Because so far, we haven't identified anything that cures the disease. And so far, we don't really have very good evidence yet of anything that prolongs survival. So that means it's a negotiation process. What's your level of anxiety or worry? What's your level of aggressiveness versus not? I have patients who'll say, gee, you've described the risks, the benefits, the side effects. The only thing I can guarantee patients is that they will feel different and probably worse when they go on systemic therapy or chemotherapy. And so, do they really want to undergo that on the possibility that it might be helpful for them? And there are those patients who are going to say, absolutely, I want to do everything possible, reasonably possible, to try to help my cancer and help me to live longer or live better. And there are others who are going to say, Doc, thank you very much, but I feel great right now, and I would really not want to trade that for anything at this point in time. And they're both right answers for those individual patients. So it is a gray zone, and you can't just pin it down to that. It's also a moving target, because what we said a few years ago may be a little bit different now as we have some newer options and newer, perhaps more effective options, where it may be worthwhile starting that discussion a little bit earlier. As Mike said, yeah, traditionally we've had this discussion when the tumor is a centimeter or bigger and growing at 20% a year or something like that. But with the study that we presented at the oncology meetings earlier this year with the new drug lenvatinib, we saw patients where all evidence of the tumor, at least on scans, appeared to go away. And such a high rate where the tumor seemed to shrink significantly that it starts to raise the question, should we be thinking in some patients about starting a little bit earlier? Because maybe the effectiveness is greater. So it's a moving and variable target. Sorry I can't be more specific, but that's where we are.
I agree. I stole this phrase from Steve a few years ago. He talks about living longer and living better. It's a really key component of this. So as we're trying to help people decide when to start, if your disease is starting to grow and it's in a place that we think might get us in trouble in the next year or year and a half, then that may push us in that direction a little bit more. Or if your tumor is causing symptoms, then that balance of tolerating risk and benefits and side effects is different. So I think we've gone away from our old sort of some magic size threshold to sort of really sort of what's your willingness to take some side effects? How do you perceive those side effects? Sometimes we tell people about the side effects and they go, you can never give me that. You would have to tie me down to give me that. I give exactly the same talk and the next person goes, well, that don't sound too bad. Let's give it a try. So, and all of that sort of then plays into whether or not we start and sort of where you draw that line. I find this an ongoing conversation. I very seldom decide the first time I meet somebody, either you have to start today or we're not going to start. Usually it's a process over time where I get to know you, you get to know me, I understand sort of what your values are, I have a better understanding of your threshold, how aggressive you want to be. And amazingly, when you come see a couple different ones of us that do a lot of this, we all come away generally with the same answer. For your particular case, it's probably time for you to start. For your particular case, probably not. Because I think a lot of us are using that same sort of risk versus benefit piece.
By the way, I did copyright that phrase, so you'll hear from my attorneys. Okay, next. Oh, we just blew you away with that one, huh? Sure.
The corneal changes? Oh, sorry.
There's a microphone right there.
I'm just curious, the corneal changes that come with the TKIs, any long-term, does it disappear after you stop the drug?
So with some of the drugs, and it's an uncommon complication, and it's so far been restricted and not generally seen. But this is an evolving area. I can't say that I have seen any cases yet of patients who've developed corneal complications from TKI therapy, so I don't have any personal experience to share with you on that.
So, Dr. Sherman,
Yes, Dr. Tuttle.
let's pick on Dr. Sherman. Dr. Sherman, you seem
When did you get a chair?
you seem to
I have
pass.
a chair. It's in my job title, but
You have a chair. I don't have a chair. That's the closest to a chair as I'm ever going to get. Dr. Sherman, we're going to talk about side effects of these drugs. Take sorafenib, for example. That's our FDA-approved drug. What do you honestly, not what you say at the big lectures, but in your office in, where do you work, Texas somewhere?
it's that big state.
That little, whatever that little clinic you're in. What do you tell me about the side? I'm 50-something years old. We won't get more specific. I'm growing up. I got my AARP card, so I'm 50-something years old. I've got 2-centimeter nodules in both my lungs, Hürthle cell, and they've grown 25-50% in the last 6 months. Tell me, what do you tell people about what are the real side effects and then the balance of the benefit? What do you tell people?
So we'll take a drug like sorafenib, and this is a drug that falls into a class of drugs called anti-angiogenic agents. And so a lot of the side effects are related to the way these drugs work on blood vessels. And so what are the most common side effects? Well, high blood pressure or an increase in existing high blood pressure. And I always emphasize this early on because my colleagues in oncology didn't early on recognize that hypertension was a real problem with these anti-angiogenic drugs. It was just high blood pressure. Who cares? It's not cancer, right? Except that there were patients who developed strokes early on in the development of some of these drugs before it was recognized how important it was to treat this. So we always emphasize this first on. Patients need to have well-controlled blood pressure. They need to get their blood pressure controlled if they're going to go on to one of these agents, and then we need to monitor the blood pressure quite carefully. We give instructions about checking your blood pressure at home and sending us emails once a week as you're getting started on the drug to monitor this. And we have certain drugs, certain blood pressure medicines that work a little bit better in controlling the high blood pressure than other medications. So high blood pressure can be acutely disastrous, but handle it properly, not an issue. Diarrhea. This is troublesome. Okay, we have patients who develop, one loose stool every couple of days, not too much of a big deal, or 10 loose stools a day, every day, no matter how many treatments we use to control it. Who develops the side effect and who doesn't, can't predict at this point. We know that there are things you can do sometimes to minimize it based on what you eat and medications that we use to try to prevent or treat it, but it can be for some patients a very debilitating problem and uncomfortable and embarrassing. So it's very important that we be upfront and let people realize that. Fatigue. People often will feel very tired on these medications. Don't know why that is. And sometimes it can be eventually the limiting factor of the therapy. I have patients who get tired of chronically feeling tired. And we're talking about drugs that once you start, you probably tend to take until they stop working, which could be years later. I have patients who've been on these agents for 10 years now, and they feel tired all the time. That is a reality for which we don't have a great solution. So those are the core three that are universal to these types of drugs: high blood pressure, diarrhea, and feeling tired. Then for sorafenib, there's also high frequency of skin rashes that affect the palms and the soles of the feet that can be painful. And we can often help that with a variety of creams and ointments. and good, good care to the skin. But I've had patients who've had significant pain that has limited their ability to walk. And that can be a limiting factor to the use of the drug. There are skin cancers that can develop when you take a drug like sorafenib. It's very specific to the way sorafenib works versus some of the others. But 15 to 25% of people can develop small skin cancers that we might just have to remove. And they're usually not a damaging problem, but it's a reality that people need to be aware of. So we kind of go through lists like that. Skin, high blood pressure, diarrhea, feeling tired are the core things. Excuse me? Again, there's an array of rashes that people can get. Erythema multiforme is one of them. We can go through a list of a lot of the rarer complications that do develop. When patients have had radiation treatment to their neck, I tend also to caution them about the risk for fistula formation, basically a hole that forms between the airway and the esophagus, which can be very serious and very problematic. And so we look very carefully at the risk and benefit balance in a patient who's been radiated like that. If a patient has active bowel infection or diverticulitis, that also can increase a risk for a complication called a perforation of the gut. You get a hole in the wall of the bowel. So there's a lot of rare and uncommon things that happen. As an endocrinologist, I also emphasize that many patients who take sorafenib or similar drugs need a higher dose of thyroid hormone to maintain their TSH suppression, and may need to start taking vitamin D because they are more likely to develop vitamin D deficiency when they're treated with drugs like this.
So yes, go ahead. Oh, I'm coming back to that. I am not buying that used car. He's not done yet. Yeah. I don't know how he enrolls anybody on trials. Yeah.
So I have a couple questions. I have had 4 radioactive iodines. I've done Nexivar and then Sutin, and I had a nurse practitioner tell me that Sutin wouldn't cause a stroke, but I had a stroke, and I heard you say something about that. So is that Sutin might cause a stroke, or is that?
So any of these drugs that work on the blood vessels can be associated with a slightly increased risk for blood clots as well as bleeding. And so there is an increased risk for blood clots in the legs or for stroke, particularly also associated with hypertension. So these risks do happen.
Yeah.
I had a patient on clinical trial who was coming to see me from Las Vegas, and she developed a blood clot on the airplane. And fortunately, no ill effect from it, but she had to come off the drug and off the clinical trial. These are known side effects that happen infrequently, but they're real, and they do happen to people. There may be other factors that increase the risk in certain people. So if you combine this with somebody who has a clotting abnormality, which we see increasingly, who is potentially on, say, birth control pills, which can also increase a little bit the risks of clots in certain people with a predisposition. You kind of add these things together, you can see a slightly higher amount. It's not a common side effect, but I would not look at somebody and say, Sutent didn't have anything to do with that.
Well, and we found out that I had that clotting gene after the fact, and I was on birth control, so whoopsies.
And it may have happened without the Sutent either in that situation.
Yeah.
My wife does gynecology, and unfortunately I hear of that combination all too frequently.
So you two are kind of my next step as a doctor, because right now, and I also wanted to see...
he has appointments open next week.
It's not what I hear. Have either of you treated patients? I'm on clinical trial phase 2, MEK 162. There were 7 patients that had thyroid cancer in the first group, and I just was curious to see if either of you had treated any of them.
I'm not involved with that particular clinical trial.
Okay.
But the concept behind the drug is an appropriate one for thyroid cancer. So this would be your 3rd treatment so far?
Correct.
Right?
Correct.
Okay.
And if it doesn't work, then I'm coming over to your ways.
Well, we've got more trials in development, so stay tuned.
Let me ask you, Dr. Sherman, because that whole laundry list...
Wait, did you have other questions, by the way, before he launches into another diatribe?
That whole laundry list of... so you can fix my blood pressure, you're going to give me diarrhea, I might get a rash. What was the other one? I lost track.
A hole in your
Fatigue,
colon.
and I'm going to feel bad. Yeah. So, dude, sign me up for that. So the benefit must be astronomical. So what is the benefit? Because I'm still trying to decide whether I'm going to take one of your drugs. What's the? Don't give me your crappy clinical trials answer. Give me the is this going to work for me answer.
Well, the answer is I don't know if it's going to work for you until you take the drug. There is no guarantee.
That's fantastic. Does that stink?
Listen.
He's the best in the world at this, and he just told me it didn't work. You're an awful used car salesman.
I don't want anybody to go on therapy, being given a song and a dance. You've got to know realistically what's involved and what to expect, and then be prepared to make a knowledgeable decision. Now, having said that, what's the benefit, Dr. Tuttle?
Yes, sir.
Okay, I'll give you examples. I can show you the statistics from the trials, but I'll give you real-world
I
examples.
don't care about the trials. It's me. It's my chest. Is this going to help me, Dr.
Well, if it's
Sherman?
you, I'm not going to prescribe
Never mind.
anything.
This is...
You're going to have to see the other Dr. Sherman for that. No. So where are the benefits? Examples. Patient of mine, 80 years old, came in with papillary thyroid cancer growing out of his neck, blocking his esophagus, couldn't swallow, encased his carotid artery, so he had partial blockage of the main blood vessel going up to his brain. Had surgery at an unnamed local hospital in Houston near my own, where the surgeon went in and said, gee, I don't know what to do here. Close this back up, send across to MD Anderson. We treated that gentleman with a different drug, not one of the tyrosine kinase inhibitors like sorafenib, because of this blood vessel involvement. I did not want his blood vessel disintegrating. Treated him with a different drug that targeted a BRAF mutation that we found in his tumor. Shrunk his tumor. He could swallow. He spent the next 2 years living a very high-quality life with improved oral intake, felt good, went to dance classes each week for his Parkinson's disease, and died from a complication of his Parkinson's. Okay? Did I cure his cancer? No, but I helped to treat some of the symptoms and the problems that he was having from it. So being selective about how you can help and whom you can help. We have patients who have had shortness of breath because they developed fluid in the lungs or because of progressive lung metastases from their thyroid cancer, and have improved their quality of life by improving their breathing, which I hear is actually kind of an important thing. Even in New York, you still got to be able to breathe.
It's still hard to breathe in New York. Yeah.
Thus, I left. So, there can be symptomatic benefit. There's also psychological benefit for some people. And this goes back to the question of, what kind of person are you? Do you want to be aggressive or not? Because there are many patients who derive benefit from the thought process that they're doing something. And I have tried to undersell the benefit of the drug so that they're not sold a story. And yet, despite that, they're willing to give this a try and see if it helps them. And for those individuals, there is that sense of benefit. There's also another side effect or risk. Right, the cost. Another critical factor in assessing the risk and benefit of this is, what does it do to the patient's finances and what they're going to be at risk for, because these drugs, street value can be $10,000 a month. So what's their insurance going to cover? What are they going to have to cover out of pocket? What's it going to do to them in many ways? But we've seen patients with some of these drugs clinically do much better. We've seen data from the cabozantinib phase 3 trial in medullary thyroid cancer that actually shows that patients whose tumors had a specific mutation lived longer when they were treated with cabozantinib. So we have a survival benefit, not cured, but they actually live longer. And so there are accruing benefits with time. for the right patient.
So I get it if I'm symptomatic. If I'm symptomatic, I'm willing to take your drug because I feel like I'm getting hurt and I can't breathe and I got a big mass. What if I'm not symptomatic? I've got CT scans and they're getting bigger. Getting back to where we started. If I'm not symptomatic and they're getting a little bit bigger, what's the benefit of the drug in that situation?
Undefined. I mean, we can slow down progression and maybe prevent symptoms from developing or delay the development of symptoms. But that's a little bit harder to prove to somebody. It's kind of like saying, yeah, you got a bone density that says you've got osteoporosis, so we're going to treat you with a drug to prevent you from developing any symptoms or problems. It's sometimes a little harder to swallow. Or we say, yeah, you've got high blood pressure, and I'm going to treat you with a drug so you don't develop a stroke or a heart attack. But I'm asymptomatic from this, right? So, it's somewhere in that range. There's better evidence of benefit from treating osteoporosis or hypertension, but it's still somewhat taking it on faith, which is treat me so I don't develop a problem down the road. That's why we try to wait as long as possible. And the ideal time to start these drugs is 1 day before the complication develops. That's the guesswork we're trying to do, to push that off.
You'll often hear us say, do something before something bad happens. And most of the time when I'm looking at your CT scans and pictures, what I'm trying to figure out is if we wait another 6 months, if we wait another year, is something bad going to happen? And that's a guess. We're usually fairly close to right because we do a lot of it. But the other thing I find people that don't use these drugs are much more enthusiastic on you taking these drugs. So part of the reason I put Steve on the spot here is in our situation, it's my medical oncologist that actually pass out the drugs and deal with the side effects.
So you can turf the patient to somebody else and get them off your clinic schedule.
It's marvelous. I've never caused a problem with a rash. I've never caused a stroke. We can keep score, but I'm doing pretty good on that one. But that's why I put Steve on the spot with these complications, because in his place, it's the endocrinologists that are actually using these drugs as well. So he knows firsthand how these things sort of go. Questions? Yeah, run to the microphone for me, will you? Only because they're recording it there.
Actually, I have three. Excuse me. One is I've been on sorafenib and Afinitor for 2 years, and it's working well. But I was wondering when the results will be published because it's a trial. The second question has
Where are you being treated?
It's Sloan. The second has to do with the drug holiday. It's working well, but the only side effects are the gastrointestinal, and they're pretty bad. So I was just wondering about if I could take a drug holiday, what the cost benefit of that would be. And the third question, I was just reading here about tincture of opium in treating
wonderful drug.
diarrhea. But I'm wondering.
Which cancer do you have, by the way? If I can
It's a papillary.
Papillary, okay. Because the medullaries know about tincture of opium because they're getting treated with that for the diarrhea that they get from medullary cancer itself. But
I'm worried
great drug.
about the addictive question.
It's not absorbed.
Oh, it's
It
not.
stays in the gut, yeah.
Because when I do take codeine, it works wonderful, much better than Imodium or anything.
Tincture of opium, fabulous
Oh,
treatment.
great, I'm glad to hear that. So if you could, answer about the clinical trial and the drug holiday.
Yeah. So I'm not sure when the clinical trial is going to be published. This is a combination trial we've been doing of sorafenib and Afinitor. It's an mTOR inhibitor. So it's a different combination where we're trying to block two pathways. And we've seen some pretty astonishing responses, especially in Hürthle cell cancer. So several of our Hürthle cell cancers have responded very well to this and for long durations. The side effect profile has been a little worse than using sorafenib alone. We've seen some platelet
How did you
problems.
convince people to do that then? Because I just told you how bad sorafenib is.
Well, they could either you could go to Dallas and take sorafenib, or you can stay in Manhattan, see plays and all that sort of stuff, and get chemo. What's the balance there? Oh, you're not in Dallas? No, that's where that other place is. Houston.
They have other problems there.
I guess that's probably true.
That's
So I'm not entirely sure when the plan is to publish that, because we still have folks that are on that trial and they're staying on. But we've moved on. We're developing other trials on that same concept that's going down. In this particular trial, we've tried to steer a little bit away from drug holidays. We've occasionally had to do it, particularly with the Afinitor, and give folks a few days off. But mostly we've tried to keep folks on it, which is a little different than the kinase inhibitor stuff. You guys do holidays, seems like every other week.
Yeah, well, we take a liberal approach to holidays. If the patient's off therapy, then I take the day off too. So, the sorafenib and everolimus or Afinitor protocol, those data were preliminarily presented at oncology meeting last year and was sufficiently encouraging to justify moving forward with planning larger trials, especially in Hürthle cell carcinoma. And so Mike's colleagues at Memorial are taking the lead in that effort. It certainly is encouraging. The toxicities it's not just the sorafenib. Obviously, the Afinitor has its own set of problems as well, and some of them can be really push one to have to take a drug holiday so that you can breathe. And so some of the pulmonary complications that people can develop, have required people to come off of therapy at various times. At our institution, we've had a phase 1 trial combining vandetanib and Afinitor, and we've seen that as a particular problem where we had to stop therapy for a while in order for lung function to recover from a complication of the Afinitor. But drug holidays have a role, in the design. It's very important that we think of how we treat side effects or the side effects that patients get. There are medications we can give for the problem itself, like the diarrhea or the hypertension. Often, people benefit from, depending upon the drug, take 2 weeks off your, exanib of choice and restart at a slightly lower dose, or sometimes just restarting at the same dose, but giving them that time window to recover and not necessarily get the same side effect to the same degree of severity when you restart. So, we can kind of mix and match, but having said that, it still has to be personalized. So I have one lady who, she's one of my patients who's been on drug therapy for 10 years, literally, and she's on probably her 7th regimen at this point. But for a long time, we treated her with sunitinib, with Sutent. And that is a drug that has kind of a funny dosing schedule. The traditional was that 4 weeks on and 2 weeks off. And then we came up with, 2 weeks on, 1 week off. But she had a problem, which was that during the 1 week off, her tumor would grow. I mean, she could not even go 1 week without therapy because she would, this tumor that was sitting right here would palpably expand and then contract again. So up and down, up and down. So we had to come up with a different continuous cocktail for her to keep this under control. So again, it's always got to be personalized. And you have to treat each patient creatively and come up with the regimen or the dosing or the interruptions and things that work well. Have patients, for example, on drugs. I said these drugs that target the blood vessels. One of the things that they do is they slow down healing. And if they need surgery, you've got to come off the drug for some length of time, varies depending upon what drug it is. And then, they have their surgery and then they go back. You have to take another couple of weeks before they can go back onto the drug. So there are drug holidays that come in to allow other medical interventions. We've got one patient who is on a drug holiday now, and we're watching him very closely, but he needs surgery for cataracts that developed as a result of radiation that he got to his eye because he had a tumor that metastasized to the back of his eye. So we saved his vision a couple of years ago, and he's a photographer. So he needed that eye. But now, a few years later, after really great vision, he's developed a cataract because of the radiation, preserving his quality of life, his function. We're taking him off the drug for a while so he can get the cataract fixed so he can go back to being a photographer. So we got to work with each patient individually.
So I frequently get asked that there's a full dose of this medication and my patient has such side effects they can't take the full dose. They have to be on the half dose. does that mean the drug's only going to be half as effective, or do I have to worry about that and struggle to get to the high dose? What's the story on that?
He asks really good questions. He also tends to ask questions that he knows we don't know the answer to.
I just said people ask me the question, so I need to know.
So you want to know what to tell them? Yes, Am I supposed to teach you now?
Again, consistently. I respect my elders.
You're on this age thing today since early morning. You missed the story I told, though. I'll tell you later.
I'm sure
Okay.
I will.
Something about a barbecue joint in North Carolina. But anyway, we don't know the optimal dosing for these drugs. The traditional oncology model was, in a phase 1 study, you're trying to figure out what's the highest dose that you can safely treat a patient with without causing deadly or intolerable side effects from the drug. And then, as you kind of like gradually increase the dose, whoops, 2 out of 3 people had a really bad side effect. We will back off to 1 level just below that, and that's the dose we're going to deliver this poison at. Because that's the traditional chemotherapy approach, where with the traditional drugs, the highest dose, the highest concentration had the greatest effect. With biological therapies, and these current chemotherapies kind of fall into that same category, that model of dose response doesn't necessarily fit and doesn't necessarily work. And so the companies, when they do these phase 1 studies, still follow the traditional model, but it's not necessarily identifying the optimal dose. So here's the example from vandetanib's experience. Drug used in medullary cancer, 300 milligrams became the standard starting dose because that's what was identified early in drug development as the highest tolerable dose. Doesn't necessarily mean that that's the best dose or the only effective dose. And at some point, there was a small trial that was done, led by an Australian group, that suggested that, well, if you start at 100 milligrams, that seems to work pretty well too, not 300. And the FDA looked at this when the drug was approved and said, well, you've demonstrated the 300 milligram dose works, or starting at 300 milligrams and going down on the dose as people develop side effects, that works, that's great. But does that mean that that's what you have to do? And so they said to the company, you also need to do a study to look at what happens if you start at the lower dose and randomize people to either starting at low dose or high dose. Is the outcome equivalent? The study is still ongoing right now. There may be people here who are in that trial where they were randomized to one or another starting dose. So this is in evolution. I know with cabozantinib, we started the 140 milligram dose in a lot of people. Also started 60 milligram dose in a lot of patients. If I'm concerned, they're going to have a really hard time tolerating the full dose. And we have patients who are benefiting from as low a dose as 20 milligrams a day. So it's individualized. To complicate matters further, and to teach Mike something that he hasn't heard before.
Can you write this down for me? This doesn't happen a lot. Write this.
What, that you have to write things down? As you get older, Mike, you have to write things down.
I keep lists now, yeah.
The dosing may need to change over time. And there's evidence with some drugs that if you treat for a very long time, the body may handle the drug a little differently, and the levels of the drug in the blood might go down. And so there was an example that was published recently of a patient treated in France with sorafenib that stopped working. And they tested the drug levels in the blood, and they said, lo and behold, they were much lower than what they had been to start with. And so they upped the dose. They went above the standard starting dose even higher. And that patient ended up on twice, not half therapy, but double dosing in order to maintain drug levels. So we've got a lot to learn. Need to do some more research. We need people to sign up for clinical trials to do that research. But anyway.
He's right. I had no idea. Anybody else have a question for Dr. Sherman? Yes. Yeah, go ahead. Because otherwise I'll keep going. This is great fun.
So I'm doing this via text. This is my co-facilitator in Fresno that's asking, what's the most promising treatment other than surgery for those of us that don't respond to RAI, that are no longer avid? What's the most promising?
That's your disease, right? You treat that stuff.
Observation. So what's the most promising treatment for the ones that don't respond to radioactive iodine? So it depends on sort of which group we're talking about. If we don't respond and we have disease in the neck, then it's usually surgery or external beam radiation, some localized thing. If you don't respond because we have progressive stuff in the lungs, this is really easy. We don't know. True story. Which one of these drugs you start with, because on the guidelines it still says you can start with one of the FDA-approved drugs, or you can start on one of Stephen Mine's protocols. Experimental. Remember, in many cancers, you have to fail what would be some standard treatment chemotherapy before you get on experimental protocol. And because we don't yet have survival benefit, it tells you that we don't know that we have the perfect drug yet. If I'm still willing to enroll you on one of my clinical trials with Afinitor and sorafenib when there's an FDA-approved drug. So I think it's really a critical question. But right now, I think we're still open. And we're going to have problems if another drug gets approved shortly to know which drug do we start first, what sequence do we do. All of that, I'm not certain we know very well.
So, as always, Mike is sometimes right. Just like how a stopped clock is correct twice a day, right? Okay.
And I'm doing this for free. Okay. Normally when we do this and he abuses me, I'm getting paid, and I feel better about that, but this is free. Yes, Professor Sherman.
So, he is correct. We don't know the right answer to that question. And in part because as of now, there's been no head-to-head trials comparing drug A to drug B. The large phase 3 trials, the two that were done in medullary cancer, vandetanib and cabozantinib, the large randomized trials done in differentiated cancer with sorafenib, lenvatinib, vandetanib, you name the nib, right? None of them have been head-to-head. It's all been against placebo because when those studies were started, that was the standard of care. And the gold standard of saying which is better is a head-to-head comparison, patients randomized to get drug A or drug B, and then see which one does better. The days of randomizing against placebo are behind us, but it's not quite clear to me that there's sufficient funding, opportunity, or patience yet to do head-to-head comparison trials, but those are necessary. So we have to kind of guess from reading the real careful details of study design in trying to interpret which might be better. So having said that, yes, Mike talked about if we get another drug approved for differentiated thyroid cancer. This is where I disagree with him. I do think that the drug that's likely to get approved next is a drug called lenvatinib, and it will be the first drug of choice and probably superior to sorafenib in treating progressive radioiodine refractory differentiated cancer. The study designs were quite similar. The patient recruitment characteristics were quite similar, but the outcomes were really quite different, with a far greater level of effectiveness seen with lenvatinib. And for the first time, a small but real percentage of patients in whom all scan evidence of disease disappeared. So I think that will replace sorafenib and become the first treatment. Nonetheless, we've yet to prove that people live longer when treated with that drug. But it will, I think, change some of the paradigm in thinking about when we start patients, or even potentially application to other scenarios where you have a drug where 2/3 of the patients get significant tumor shrinkage, get partial response, and progression-free survival increases 5-fold compared with placebo. It does raise some very interesting possibilities of, is there an option for using this drug when patients are first diagnosed to significantly shrink tumors before surgery even? Or using a drug like this after surgery for a patient that Mike, through his very wonderful research, has identified is at high risk for recurrence of tumor. If this were breast cancer, we'd be calling it adjuvant therapy, for a high risk for recurrence disease. So I think that we're going to see an expansion of the paradigm, or combining this with some interesting other approaches to therapy. I do think it will be the first drug to use. And full disclosure, I was an investigator in the trial, the senior investigator, and I do receive consulting fees from the company. But I also received consulting fees from the company that makes sorafenib and was involved with that trial too. So I think
he used
my
to.
conflicts are a toss-up.
Now, I think that's exactly right, because before when we were picking these drugs, nobody was sort of clearly making things shrink. Nobody was clearly giving a better benefit, and so we were picking them based off side effects, which were the ones that I thought you could tolerate the best. Now with lenvatinib, that is starting to look like it's a better drug. I think that's probably right. So it gets me out of the least side effects and maybe toward picking something that's likely to respond. It's a great problem to have, and it's a great step forward. It's probably not the total answer yet, but boy, it's moving in the right direction compared with where he and I started 15 years ago, where our job was to hide people from oncologists because they might give them some poison. Yeah, I do it as well. Yes, sir.
Curious in your fictitious patient that has the lung modules and stuff like that, just a few quick and easy problem. But for those that might have more, or for ones that now is moving into our bones, what is the next direction you would see as far as these clinical trials?
Oh, that's a great question. So we often see folks that it just hangs around in the lungs for a long, long time, sometimes on drugs, sometimes on not, and then it pops up out in the bones. We've done a reasonable job, if it only pops up in one or two bones, of just sort of fixing that one or two bone at a time with surgery or external beam radiation. Most of us are now using bisphosphonates, so Zometa or one of the bisphosphonates or rank ligand inhibitors. They're medicines that were largely used to treat osteoporosis, and ideally they make the bones harder and a little less hospitable. And in other cancers, they decrease the number of bone mets that pop up. So we definitely do that. We'll often see patients that are on sorafenib or lenvatinib or one of these, and we're holding 99% of their disease under control, and you just have one place pop up in a bone. We continue the drug that we're on and just treat that one place, because if we're holding 99% of it at bay, that's probably a good thing. So right now it'll be those combination therapies. How about you guys?
So bone mets has definitely been the one of the biggest drawbacks with the use of the new agents because of very limited effectiveness on bone disease. Some of us got excited about cabozantinib, the medullary drug, because of anecdotal experience we had in treating patients with bone mets where it really looked like the disease melted away. And one of my first patients had a golf ball here that basically completely disappeared with cabozantinib. And then we got encouraged because the drug had evidence of being very effective in prostate cancer with bone metastases, suggesting that there's something about how this drug works that makes it useful for targeting the bone. Now, unfortunately, the larger trials to look at prostate cancer bone metastases were unsuccessful. It did not prove the degree of benefit that was initially anticipated. And that was a big bummer that it didn't work out in the larger studies. ITOG is doing a trial currently with cabozantinib. It's led by Manisha Shah at Ohio State. And we're looking at patients who've had progression of their thyroid cancer, differentiated thyroid cancer, after one or two treatments like sorafenib. And one of the areas we're specifically focusing on is to look at the bone impact of cabozantinib therapy in those patients and see if it's helpful. So there are trials trying to specifically focus.
And I'm not teasing this time. The Schlumberger has a trial with an alpha emitter. Do you remember what that one was?
Yeah, so there's something called radium-223, which is a radioactive isotope of radium, which is usually radioactive anyway. Radium-223 seeks out certain areas of the bone. And there's suggestion in certain types of bone metastases, like the ones you see in breast cancer, that can be a very effective way of delivering a huge radiation impact just to the area of the metastasis. And so in France, at the Gustave Roussy, formerly known as the Institut Gustave Roussy, they are studying the single agent radium-223. ITOG actually has a trial that is under development combining radium-223 with another therapy to specifically focus on bone metastases and differentiated cancer. So there are a number of things that people are trying to work with.
The sorafenib, lenvatinib dual there. One endocrinologist yesterday said that the side effects of lenvatinib, or that's how I interpreted it, but it's a more difficult drug to take, and I assume she meant the side effects. Is that your?
It's a common story on the street that was not really borne out in the phase 3 trial data, quite frankly. Some side effects are much more prevalent with lenvatinib. So 40% of patients had very significant rise in blood pressure that required aggressive medical therapy. But in terms of the kinds of effects to requiring lowering the dose or interrupting the dose of the chemotherapy, those were essentially the same as what was observed in the sorafenib trial. Sorafenib is a hard drug. Both of them are hard drugs to take, and in our experience, having used tons of sorafenib over the years, and now with lenvatinib, I don't think the data really support lenvatinib being a harder drug. They're both tough drugs.
Yeah, and that's what we didn't participate in the lenvatinib trial, but everybody that I've asked about it that did put patients on the lenvatinib trial said exactly what Steve did. Much less rash. It's a different toxicity. You have to really make sure you got the blood pressure under control. But if anything, maybe even a little bit easier to take than sorafenib. So that's a common theme from the people that were actually using the drug in the trial. I'd heard the same thing on the street from people that didn't use it. So I think that's a rumor that can be quashed.
And the streets of New York are a tough place.
They're a difficult place. You want to tell people where you grew up?
New York. In the subways. On the streets.
Yeah, here we go. Homeless and in Queens. Yeah, exactly right.
Well, it was Whitestone. Washington slept there, though. So.
Yeah, go ahead.
Do you think in the next 5, 10, 15 years there will be much difference in the treatments? Do you have a high level of confidence that maybe there'll be some big developments that really increase survival and some drug therapies?
Yes. If I didn't, I would go home and I wouldn't come out here. I don't have any doubt. For the ones of us who have been doing this for a while, if you look back where we came when Steve and I were fellows, with the options that we had for this disease, they were dismal. So now we have options of making radioactive iodine work better. We understand the molecular biology. We're understanding these new drugs. We can now do genomic sequencing of these tumors where we're no longer guessing, let's put 100 people with some cancer on. Let's put 100 people that have this specific mutation and treat with that drug. So yeah, I think this is really an exciting time. And I really think we're going to get drugs that will improve survival or some combination. So yeah, I think this is going to be an exciting time. That's my bias. Steve?
So of course, when Mike was in training, DNA hadn't been discovered yet, but...
Sure, that's true. I just didn't know about it.
So here is my personal historical perspective. About 15 years ago, I was asked to do a symposium lecture at the American Thyroid Association entitled Multi-Center Clinical Trials in Thyroid Cancer.
It lasted 30 seconds.
It was the easiest lecture I ever had to give because there were none. Everything that we've just been talking about, none of that existed 15 years ago. 10 years ago, I was still banging my head against walls, literally trying to get drug companies interested in thyroid cancer. When we did the very first trial, phase 2 trial, with a drug called motesinib from Amgen, we had to sneak patients onto the phase 1 trial because Amgen wasn't thinking about thyroid cancer. We got a few in there, thyroid patients, because they were eligible, but it wasn't on the company's radar screen. Now, when 3 of those patients responded to the drug, suddenly it was really on their radar screen, and they came back to us and they said, gee, what is thyroid cancer? And how do we study this? We did a study with that Amgen drug. It really should have been 2 separate studies. There should have been one in medullary cancer and one in differentiated cancer. They couldn't sell 2 different studies to company leadership at that time. So we had to come up with a creative way of combining the 2 under one title and one protocol, but really 2 completely separate studies. That's where we were 10 years ago. So we've come a huge way structurally. We've come a little way in terms of improving the outcomes of patients. But this conversation would not have taken place 10 years ago.
Okay, I was diagnosed with thyroid cancer in 2007, had my surgery. At the end of 2008, my second daughter was diagnosed with metastatic nasopharyngeal carcinoma. Okay, and she did anything and everything her doctors wanted to do, and they were shocked. You know, they didn't think, because she was so sick the whole time, and we lost her in 2012. A year later, exactly a year later, my youngest daughter was diagnosed with ovarian cancer. And to have 3 cancers out of 5 people in a family, my older daughter hasn't been touched yet. So, I mean, where can I go to check?
So since Steve and I both work at cancer centers, unfortunately, we hear these kind of stories. So in ours, we have a wonderful genetic counseling group that their specialty is searching for any sort of genetic signature or some syndromes and things that we've never heard of. So in my patients have the panics with like odds, takes the face of the young sort of stuff. We'll send them to our medical geneticists because they know the world of medical genetics to see if there's we've never heard of. If I want to respond, most of the time there's not. And there's not a specific gene to know. But families like to. So
could it be environmental?
Well, that's what I always call it. So if you have 3 or 4 or 5 members in the same family, it could be genetic. Or it could have been everybody was exposed to the same thing in the house. And that's obviously really difficult.
Well, it turned out that one of my husband's nephews had the male version of the ovarian cancer. It was a germ cell, and he had it at 18 months. And they caught it so early that he didn't have to have any type of treatment. So there was one link.
What our clinical genetics guys do is they send you a packet in the mail that has this family tree on it, and then you got to do homework for 2 or 3 weeks to figure out why everybody in the family died and how many are still alive and what cancers that they had, so that then they can look at those big pictures and see if there is some syndrome or whether this is random chance or this is something we don't understand. But often when we have those kind of tragic sort of family histories like that, I'll turn it over to our clinical genetics folks.
Absolutely.
Yeah, well, the daughter with the nasopharyngeal, the last place she was treated was Memorial Sloan Kettering on Long Island.
Oh, yeah, we've got some satellite. We have time, I think, for 1 or 2 more questions. Any? Yes?
So I have a couple of questions. My first is kind of short. When you talk about the breathing starting to become difficult because of fluid, are you talking about pleural effusion? Or
Yes.
And my second is, for these
You're right,
drugs...
that was short.
Yeah. My second is, for these drugs, which ones, if any, are good for hurdle cell?
Well, up until recently, the answer would be not much. But again, as Mike talked about before, the data from the sorafenib Afinitor trial at Memorial Sloan Kettering was very strongly suggestive of benefit, particularly in the Hürthl subgroup. The other, in the lenvatinib trial, the patients who had follicular or Hürthl cancers responded better than the patients who had papillary cancer. And so it's not nearly as strong a suggestion as what they saw in the combination regimen, but clearly there was benefit in the subgroup.
Some of the folks at our place just looked at sort of really deep the molecular genetics of Hürthl cell. And we used to think these were just cousins of papillary and folliculars. It turns out they're probably not. They're a whole different pathway. And it turns out mTOR inhibitors and affinitors, if we'd have known that before, would have been predicted to work in Hürthl cell. So that data has just come out over the last 6 months or a year. And so there's a lot of groups looking at that data that says, okay, Hürthl cell is not just a cousin of papillary and follicular, and modifying these trials may not work. We may need to design specific other trials for Hürthl. So I would imagine we'll see some other that do focus on that mTOR PI3 kinase pathway that seems to be more involved in Hürthl cells than others. So I think it's because we lumped them in before. Now we're recognizing maybe they are unique, and can we target them uniquely? So I suspect we'll see some changes in the trial designs as we move forward with those guys.
Yeah, I think if we were able to get away with trials that enrolled over 300 patients with medullary cancer, we can do trials that are focused just on Hürthl cancer.
Absolutely.
Anything else?
Yes, in the back.
My question is, how do we get the media and the rest of the world to stop calling this a good cancer?
How do you get the media and the rest of the world to stop calling this a good cancer? Yeah, you let them get it. Steve?
So, remember, there's some basic statistics. The rate of diagnosis of thyroid cancer is increasing faster than that of any other cancer. It is the 5th most common cancer in women. And what really troubles me and what drives me forward is that the rate of death from thyroid cancer has not dropped. And we hear people say, well, it's not going up like the rate of diagnosis is. It hasn't gone down. And the rate of death from almost any other solid cancer has. And that's hugely different. So even if it were the good cancer before, it ain't anymore. Okay? This is a disease that unfortunately people die from, and far more people develop very serious problems from. And there are lots of folks who do really well, fortunately, and the kind of work that Mike has done over the years to help us identify who are the people in whom the less we do, the better, is incredibly valuable. But there's still this core and not shrinking group of patients who get into trouble from this disease. And that's what we have to keep hammering home the need for, and just keep speaking publicly and writing and imploring agencies and funding, et cetera, to focus on, because this stuff is essential.
I came late, so I hope you didn't answer this already. But I just came from the lecture about the molecular genetics of thyroid cancer. And so I'm wondering, in cases like poorly differentiated papillary thyroid cancer, where thyroglobulin does not necessarily show what's really going on in your body, if at Sloan you're using some of that detection of looking for BRAF or NRAS or whatever the mutations are in the person to find out how are they really truly responding to the TKIs.
Are you referring to testing the tumor or looking for circulating DNA with the mutation?
No, I'm looking for, I believe, like, let's see, you must know Dr. Singh. Right? Dr. Singh did my husband's surgery in 2010, January 2010. So we got a report about the solid tumor that was taken out. But no, I was talking about the circulating blood in a person that's now undergoing TKI treatment to see if that's more effective than looking at thyroglobulin that isn't such a great...
Steve will give you the real answer. So,
okay.
Well,
again,
that's been our career for all these years. If I get stuck, and in fact, if you call me, it'll ring on his phone. It's fantastic. It's perfect. So
that's what your wife said.
Yes. me to my own joke. I hate traveling with him. So it's really an interesting area because there are lots of group at our place. We're not yet doing it for thyroid cancer at our place. But looking at circulating tumor cells, looking at circulating DNA, where you treat somebody and then don't wait 2 months to see what happened. Did we make those cancer cells go away in the bloodstream? Did we make some other clone develop that's going to be resistant? So it's still kind of in the nascent stuff for us. But you've been doing circulating tumor cells for a while.
Yeah, so we have a program in developing new circulating biomarkers in thyroid cancer. And so this started with looking at circulating tumor cells using a standard FDA-approved technology that is predictive of outcomes for women with breast cancer, for example. And we couldn't find circulating tumor cells in patients with papillary or follicular cancer, but we did in medullary. And actually the data suggested that measuring circulating tumor cells was more predictive of long-term outcome than the vaunted calcitonin doubling time. And so, we do have some evidence that we can potentially apply this, but it's a difficult and it turns out to be fairly expensive technology, and so we began exploring other directions. And we were still troubled by the fact that we couldn't find these tumor cells in patients with widely metastatic papillary cancer. So in parallel to that line, we've been working with circulating DNA and another molecule called microRNAs. And so this is all very active research in our institution. Gil Cody, who was presenting a talk earlier today on molecular biology applied to medullary cancer, Gil has a grant from the NIH to study specifically being able to detect the DNA that contains RET mutations in the blood of patients with medullary cancer. And so he's developed this methodology, and we're beginning to look at it now sequentially. For example, we've obtained, very much to your point, we've obtained specimens from the Exelixis trial of cabozantinib in medullary cancer. And Gil is now going through the process of looking at the levels and the changes in the levels of the circulating DNA in patients as they were treated with cabozantinib from that trial. So rather than starting a whole new study and getting blood from patients, we were able to use what was left over from that clinical trial to try to answer that question. So there's a lot going on in this, both in terms of the patients who have thyroglobulin that's not a useful marker or who have anti-thyroglobulin antibodies where you're not sure what that means. And none of this is ready for prime time, but it is a big focus for which we have some NIH support.
So thank you for allowing us to come and do this together. I can't tell you how happy we are with this. Enjoy the rest of the meeting. This is a fantastic time for us to be doing thyroid cancer because you've seen here in the hallways lots of us work together at different institutions to try to get all at that same goal, and I'm not going to use your tagline, but to make people live longer and make them okay.
Thank you.